Let's switch to the other medicine. Dirk, I'm going to put you on the spot for this to teach us about TAS-102, the clinical trial, a little bit about the drug.
No, TAS-102 is now called Trifluridine Tipiracil, which is nicely, it's a complex word, but it's characterized.
A lot of water before you say
it's a combined drug. Trifluridine means a fluoropyrimidine analogon. I'll explain in a minute. And Tipiracil is an enzyme. The trifluridine is the active metabolite, and this is taken via cell transporters into the cell. Then it undergoes activation steps via phosphorylation, and then it acts like a fluoropyrimidine as an antimetabolite. The enzyme, which is
cooperated. Do you think it's 5-FU?
No, I'll come to this in a minute.
Sorry.
The enzyme,
come on, man.
The enzyme, which is let's say coupled with it, prevents the degradation of this molecule. So this molecule stays longer, let's say, in the cell and is not, let's say, extracted. We have seen that this drug, this trifluridine, which is not 5-FU, is also active in 5-FU resistant cell clones. So therefore, it's not exactly 5-FU. It works in 5-FU sensitive and 5-FU resistant. So we say, therefore, it is a fluoropyrimidine. It is an antimetabolite, but it's not 5-FU and may also be working in 5-FU refractory patients.
Toxicity? Toxicity
is different than, toxicity profile different than from regorafenib. Much less symptomatic toxicity, much more hematotoxicity. So as an antimetabolite, it has to be checked. Neuropathy, thrombocytopenia, and also febrile neuropathy are the adverse events.
Yeah, so really different, but some mild nausea in some patients, but I would agree with you, most people feel pretty well while they're taking
So,
medicine.
you know, it is interesting. A study that was a retrospective analysis that actually came from Japan looked at the center's experience with TAS-102 and regorafenib. So a lot of the toxicities are very predictable. So there was one toxicity that was very intriguingly the same. Fatigue was the same between the two agents, which reflects probably the status of the disease and a little bit of the drugs. But it wasn't much different between the two. We all think regorafenib fatigue, but the fatigue was the same too. The other thing is exactly this. The nausea was worse, much worse with TAS-102. In there, again, retrospective analysis, take it with a grain of salt. So the GI toxicities do belong to the cytotoxic group as well, and you do see that a little bit more. And again, the other toxicities are what you expect, hand and foot syndrome, liver toxicities were definitely worse than the regorafenib. Very interesting study. You know, because we don't have that comparative data, it's very difficult, other than our own recollection and biases, of how we remember that patient presenting to us after they got their first week of treatment or 2 weeks of treatment.
Paul, I'm going to pick on you for this. I mean, we have two drugs that are basically approved in essentially the same space.
Right.
You present them both to patients, I'm assuming, in this. How do you help decide with the patient which one of these to go to first?
Yeah, I'd say this is more art than science, and we certainly try to get patients in this setting onto clinical trials of early agents if possible. But so, for example, you know, a patient who's had a great deal of you know, hand-foot syndrome throughout the course of their disease because of their fluoropyrimidine, you know, you might steer towards TAS-102. Somebody who's got marginal counts because they have problems left over from their oxaliplatin before, you might steer towards regorafenib. So based on those toxicities, that's certainly one. And then patient preference, I think, plays a greater, you know, it always plays an important role, but plays an even greater role when the trade-offs are much more marginal.
Yeah. I got a difference of opinion?
Not really. Maybe if you want to save you know, potential bone marrow toxicity, because bone marrow toxicity was a major problem for the first two lines, you are going to regorafenib, but these are, you know, patients that experience bone marrow toxicity.
This is really an observation for me, is that we thought that when sending patients home with oral therapy that would actually be a break for them. But not only is it the fatigue and sort of different sets of side effects, but one I was not expecting is that they kind of miss the infusion unit. The infusion unit is a place where they get a little Ativan. They have Wi-Fi there, and they watch a movie, and they get spoiled. They don't get a mani-pedi, but they get spoiled while they're there. And then all of a sudden they're not going.
I want to come to your infusion area.
It's really good. It's good. Yeah.
No, but I agree with you, John. I mean, I
it's
hear
a
that
support
from
system that we're removing
so,
from
know,
them
this
on
is
some
easy.
level.
This is keeping me home. but I miss my infusion nurses. I miss being, I miss being here. I miss chatting with other patients and all that. And I think that's certainly
it's a subtle thing.
Yeah.
It's just one of those things that you might
So
mention.
occasionally, if fluids are indicated, you bring them once in a month. Give them some fluids so they.
I tell them we're going to try that chemo again.
Course.
Don't worry, we're going back. But for a while, you're going to take a break. It's also a nice moment for them if they want to take that 2-week trip or someplace when it's a good window.